Hey y'all, happy Baby Friday. We are here for another healthcare happenings. I am pleased to have my good friend Sonal here to do our, oops, sorry, I gotta turn my sound off over here, to do our second part of our E&M for 2021/2023 updates. So we've got some more questions and some more resources through and stuff I'll be putting up in the resource in the comment section for y'all so that you can see it. And I also have a surprise added special guest, our good friend Beth with Advanced Coding Services. And I brought Beth on because Sonal and I in June are going to be in San Diego to speak at her retreat that's on mastering the business of medicine, and it's going to be super cool. So I just wanted to have Beth on so she could talk about it a little bit so that it made people aware of something that's out there that's fabulous networking, nice and relaxed. And so if y'all have some questions, you can go ahead and throw them in the chat. But Beth, first of all, thanks for taking some time to come on today.
Well, thanks for having me. I'm excited to be here with you guys.
Thanks. And so people that don't know you, and I see we've got people coming on, and y'all that are coming on, Ladriba. Hey, Ladriba, how you doing? And Haley, Pam Vanderbilt's on, ladies. So
awesome. Hey, Pam.
If you have questions for Beth as we're having this first little discussion, go ahead and put them in the chat and we'll have Beth answer them for you. Or if someone and I, know the answer to it, of course, we'll jump into. But Beth, for people that aren't familiar with you and the company, like how did you get started in healthcare and doing what you're doing now?
So way back in the day, I was hired as a receptionist for an internal medicine doctor. And I was there about 3 weeks, and the office manager and he got into a fight, and she walked out and he said, do you know anything about billing? And I said, nope. And he goes, I'm sending you to school. Will you learn? Yep. And so the rest is history. I've been doing this about 27 years. So I started when I was 2 because I'm not yet 30.
Of course.
So I've been doing this a long time. In full disclosure, I'll tell you, I've been doing this longer than my son has been alive, and he's just turned 25 last month. So it's been a day or two. And I just love it. I own my own billing service, and I love servicing our doctors and providing for them. But then there was that next step of helping the next generation of builders and coders. And, we were an extern site for those big box schools. And so we would have externs come in, and oh my goodness, I was like, you guys don't know jack diddly squat, and you're paying thousands of dollars for this. So one of my goals was at some point to open my own billing and coding school where I could teach them correctly, where they could have a career, an actual career where people would want to hire them. And so we have Advanced Coding Services, and we do, if there's a curriculum out there from AAPC, we can teach it. Look me up. I have about 12 credentials. And so if I have a credential after my name, I can teach that. And we do. My goal is really to help people grow and to stretch themselves and to give them a career that they can get started and where they can feed their families. And so that's what we do. And then now that we teach you coding and we give you that, we help you get your certificate, so you're certified, what's the next step? Now you're floundering to get CEUs. And so we have a membership, but then it just kind of evolved. And I just had this epiphany one night. Literally, I'm not lying to you. I was laying in bed, I was trying to go to sleep, and this idea just came to my head. It was just kind of a brainchild. And I just could not sleep until I completely mapped the whole thing out. About 1 o'clock in the morning, I'd completely mapped it out, and I fell asleep and woke up the next morning with, we are doing a coding retreat, because this is where we get to sit with the Sonal Patels. We get to sit with the Betty Hovies. We've all been to HealthCon where there's thousands of people. And Betty, you did a great presentation, but I had questions that I wanted to ask, and I couldn't get to you because the line was 50 deep, and I had to get to my next session, and so do you, and I couldn't see you again. And so this is where we get to sit with you. We have breakfast, we have lunch together, we are in class together. There's all kinds of opportunities for networking, card games, might have a beach night, we might have a bonfire. But this is where we're all just grouped together, and it is intentionally small. I think in San Diego, because that's what we're talking about, San Diego, our retreat in San Diego, we're limited to 85 attendees. You know, HealthCon has like 3,000 people. Our retreats are limited to 85 attendees because it's intentionally small. It's intended to be intimate. It's intended to be where I can have those one-on-one conversations. We talked a little bit just a few minutes ago, and now we're going to add a brand new panel. So you want to be a consultant, and we have all kinds of people. We have Betty, we have Sonal, we have Pam Vanderbilt, Branda Edwards, Ruby Woodward, big names in the consulting world. Christine Hall. We're all going to be there, and we're going to have a panel. We'll work out the logistics, but we're going to have a panel. Like, maybe I want to be a consultant, but I don't know how to get started or where. And you guys are going to talk to us about that. We also have a professional photographer coming in that's going to do headshots. If that's something people are interested in, you know, upping their game. So, no, you're going to talk about branding and marketing your own brand. And so we're going to talk about that. And then we'll have photographers doing headshots so that people can just grow and expand. And sometimes it's, I don't know where to start. And this is getting that starting point, talking to the industry experts about, how did you get started? Betty, talk to me. I want to be you when I grow up. How did you get started? And that's what we're going to talk about, right?
Right.
Yeah.
So that's kind of the intent. Oh, and I'm wearing the shirt because we're all going to be in shorts and t-shirts. In full disclosure, I probably truthfully will be in a t-shirt and skirt because that's what I'm comfortable in. Right. You wear what you're comfortable in. I tell my students, as long as all your parts are covered, I don't care what you wear. And I don't care what you wear.
Bits. Cover your naughty bits.
That's right. Cover the bits. You can wear flip-flops. You don't have to have your hair done because there's no judgment. This is a judgment-free zone. I don't care if you're not business casual. You're at the beach. You're intended not to be business casual. This is where you're just going to have those questions. And maybe I'm too shy to be in a room of 1,000 people at another conference, but I have my own questions. And so maybe I accidentally walk next to Brenda Edwards or Pam Vanderbilt or Betty. Maybe I'm just accidentally walking next to you, and we can have that conversation as we walk to lunch together. I can get my questions answered, and I don't feel self-conscious about asking it in front of a room full of people. But I might now ask you that question, and then you're like, oh. And so when we go back from lunch, now you're like, oh, hey, by the way, don't forget we said X, Y, and Z, and, you know, somebody brought to my attention. And so I just want to make that announcement for everybody to know, so that those questions are getting answered, so that we are really speaking into the lives of these billers, coders, auditors, healthcare professionals, to grow their personal brands, to grow who they are. And so that's really kind of the brainchild of this, is to just to speak to these 85 people in San Diego.
Great. And I just put the link that I had on the screen. I put it in the chat for everybody so they can look at it. And the other thing, I made this new little thing for it. What I think is great when you look in the middle there, you know, about what's included in the retreat, you know, so all the lodging, all your meals, all the sessions. So, you know, the fee that you're paying is the fee for everything. Unless, you know, you're doing extracurricular things in San Diego, you know, after hours. But, you know, all of that other stuff is bundled in there. There's no extra out-of-pocket costs, you know, and of course, arriving there, whichever way you know are going to get there. But other than that, everything's all covered, and you don't see that anywhere either. And I think that is just a fantastic thing to do it that way and bundle it.
Exactly. Right. And that was part of the thing. Like, sometimes these other retreats are just cost prohibitive for just our typical coder. I mean, if your employer isn't sponsoring you to go, it's cost prohibitive for the person who's just trying to work to make ends meet. And I didn't want to gouge people. I want to offer a great thing. Lady's going to be there. Lady was there last year, and she had a ball.
Yay. Perfect.
But I would say,
Lady.
So I just want everybody to be aware that we're going to be on the cliffs. If you can see my screen behind me, that's literally a picture from our venue.
Oh,
You're going to
Great.
be on the cliffs. You will look at the in our room, and then the whole wall is just window because all you see is ocean. And it was so amazing last year. So many people were cold. We had to shut the windows from the ocean breeze. It was absolutely phenomenal. So just be prepared. I mean, bring a jacket, bring a sweatshirt, because that ocean breeze is beautiful, but it gets a little nippy.
Yes, it does.
So we're on the ocean.
Yeah. Oh, good. So if anybody's got any questions for Pam on the retreat, make sure you pop them into the comments, into our chat real quick before Pam has to scoot. Because I'm not seeing any people just making, of course, Pam has winning.
That's cute.
So as we give people a couple minutes in case they do have questions, some of the sessions, like you said, Sonal's doing one on branding.
Right.
Sonal's also doing one on auditing under the new guidelines,
standards.
right? So,
yep. What are the new audit standards for 2023 and beyond? Yeah.
Okay. I'm doing E&M Ninja coding training. So we're gonna work cases and play. I designed an E&M coding game, so we're gonna play that game and do things. So it's very hands-on to where you can work things, ask questions, talk to each other. There's going to be presentations on denials and risk adjustment, right?
Risk adjustment,
right?
And No Surprises Act.
What?
And No Surprises Act.
Right. Where's the gift in the No Surprise Act?
Where's the gift? Cute, clever.
About that. Yeah. I have a really dear friend of mine. He's a retired Marine. He's going to come talk to us about leadership and teamwork.
Nice.
So I'm really excited for that one. He will be our opening session on Saturday. Talk working and why it's important and why we should do it. And then we have Pam Vanderbilt, and she's going to talk about E&M. We have Brenda Edwards, and I think she's going to talk about Incident 2 and how that plays a role with the new E&M guidelines. Christine Hall, I can't remember what she's speaking on, but Christine is going to be with us. The dates are June 9, 10, and 11. Check-in is Friday, June 9th, about 4. Our first session starts at 6:30. And then we will be all day Saturday, and then all day Sunday. We're done 4:30 Sunday night. Saturday dinner is on your own, but we kind of had some moments last year of people running to the border. If you want to go, y'all go to Mexico, but bring your passports. I don't carry bail money, so you're kind of on your own there. But we had people who went to and did a bonfire on the beach. We had people who went and had a nice dinner in San Diego. We had people who just ordered pizza and stayed in the room and visited with each other. We also have card games and puzzles and stuff, so that there's activities to do. Nothing is organized after the classes. It just all happens organically because suddenly we're best friends. We're on a retreat. We're hanging out. We're just visiting.
Right.
And suddenly we're best friends for the last 3 days.
Cool.
Cool.
All right.
Love it.
So
Love it.
Thanks, Beth, for giving us some of your time today. So y'all, once again, if you're interested, make sure you go take a look in where I put the link in there for you to Advanced Coding Services so that y'all can check it out and sign up and register so that you can be among those that are hanging out with us in June in San Diego. So thanks a lot, Beth. I'm glad you could take some time with us.
Well, thanks for having me. It was great to see you gals, and we will see you in about 60 days.
Yes.
Absolutely. Love it.
Okay. Bye.
Thank you.
Bye-bye.
Bye.
All right. That was so nice that she could come on.
She was incredible, right? And telling everybody out there about this retreat. It's an amazing concept. So hopefully our listeners know what to do now. Just go ahead and sign up.
Yeah, and Haley made a comment that she can't make it this time, and this is something just so that y'all know that is a repetitive, like she's having one in Georgia in a couple weeks, and then there's one in San Diego. So she's doing them. They'll be on they'll be regional, in nature. So if you go to the Advanced Coding Services site, she'll start listing where the next ones are going to be so that you can see where they're coming. All right. Oh, Ladriba, that was so nice. Yes. She's great. So we'll look forward to that. And Grabiella is going to try to join us. So that would be good.
Wonderful.
We'll be
That'll
happy
be great.
And Sonal and I both, I'm going to do a healthcare happenings live from there. And I think Sonal, you said you were going to do a podcast live from there too.
Podcast live from there too.
So,
yep.
We'll be doing some live stuff. So that'll be
That's right
too, that y'all can join in on.
Mm-hmm.
All right, now to the business of the stuff we wanted to talk about today, our E&M part 2. So, in looking at from the last time we did our first part for this, the AMA came out with their Errata and Technical Corrections and things like that for the E&M changes and the guidelines. And they also have some FAQs and some different things that Sonal kind of sent over to me. And so I will, again, put links to all of those over in the chat box here so that y'all can go ahead and take advantage, if you don't have them, of going in and seeing all of them. The first one that I'll put up in there is the FAQs, and I labeled each one of them. So when you get them, you can see, like the one I just put in there says it's the AMA CPT E&M FAQs. So you'll know which one it is that you're going in to look at. So we have the FAQs, and then we also have the, did that one. Then we have the Errata and technical changes. Now that, when you look at that one, it's not only for the E&M, it's also for anything else in CPT where they miss something. So it's about, what, 5 or 6 pages long, I think, Sonal?
That's right.
And
it's about
they
7.
go through
Yep.
like the other sections of CPT if there's like verbiage that they needed to clean up or something like that. So it's anything like that. When they say it's the technical corrections, sometimes it's like in the E&M, for example, one of the corrections was they changed the word immediate to intermediate because they put it in there wrong. So sometimes it's just a little thing like that, but they, want to make it correct. So that would be like a technical correction that they were making in there. And then the third thing I'm going to be putting in there is from a webinar that they had that is called Advancing Landmark Updates Across More Settings of Care. That sounds really confusing, but it had, again, a lot of questions and answers that had come in during the presentation. So these are the Q&As that the presenter went through during the session, right? So am I
That's
getting
right.
all those right?
Yep,
okay.
Exactly.
So all of those links are now over in the chat so that y'all can go ahead and pull them up as we're going through things, or later, you can have them to refer back to if you want to go look, because obviously we don't have enough time to cover every single thing that was in there. But I kind of picked out a couple that I thought we got a lot of questions on, personally, both of us, and some of them where I think that the AMA misinterpreted maybe the question that the person was asking, again, due to the questions that we get. So just wanted to kind of, on a couple of them, just say, well, don't forget about this, or remember, or, if this was the question instead, kind of thing. So we're just going to go through some of them that were in there and talk about them. And then we did get some questions from people, so we will pull those up and go through those. And then if y'all have any questions, make sure you go ahead, any additional questions, go ahead and put them in the chat, and we'll see what we can get to in the time that we have remaining. So, see, my first one that I pulled in was, should the coders determine whether a patient's medical problem or illness is stable or worsening? And I'm glad the question was asked, because I know sometimes the coding professional, when they're looking at records, they sometimes know their docs, right? And they know their NPs, the PAs, and they're there every day with them, and they'll look at the record, and say, well, this is what we're meaning. This is what they meant when they put this in there. Or back in the days when we had the handwritten charts, and the whole joke, like Sonal, you put up in LinkedIn that one Friday with the scribble, and it's the doctor writing something. Those things were, you could give notes to another office from your doctors and they would have no clue what they said. They could give you notes from their doctors, again, no clue what they said, but you reading it, because you're used to this chicken scratch, you would say, oh, well, yeah, this says this, and so it got to a point sometimes with some of them, it was a disservice because you knew what it said. But if the record got asked for from a payor, and they got that chicken scratch, they were like, nope, I don't know what that is. It's nothing, so it turned out not to be the greatest thing to, be able to make those leaps too much. Right. Do you remember those things?
Of course I do. The chicken scratch. Of course. Yeah. So when we, hear questions like this, it gives us pause, right? So even though we are friendly, we think we understand our doctors and our PAs, et cetera, and what they intend on their scribble or what they intend in a documented note, it is not our job as coders to determine anything about the patient's condition, right? It has to be clearly documented in the EMR system today, right? There should be today in 2023 much fewer chicken scratch throughout the country. So it literally has to be typed in there by the doctor, the PA, whoever is in charge of that note. We have no place in making an assumption, absolutely zero. So that's how I would answer that question. It's kind of harsh, but we have absolutely no right to assign that kind of a judgment. No.
Yeah, you're kind of diagnosing the patient yourself then. So
and
practicing medicine without a license. I mean, you're stepping out of bounds there. And this is the way that it was answered. No, a coder should not determine whether that problem is stable or worsening. The patient's physician or other QHP, which is qualified healthcare professional, is expected to determine that. And that's one of the places in the assessment and plan or impression plan, whatever y'all call it in your practice, that, I found that we have to keep touching the physicians and APP in that, you have to state that, and stating that may raise the level to an appropriate level. And I say may because remember, we have 3 elements. You do have to meet 2 of them. So just because your problem addressed is high doesn't mean you have a 5. Just because it's worsening and exacerbated chronic doesn't mean it's a 4. You have to have one other piece that matches. But if they just put that it's psoriasis and it's a chronic condition and that's it, you can't make the leap there. We have to see that there's evidence that it's not at goal, it's flaring, it's worsening. So when I talk to my docs and APPs, I would always tell them, use your words. Like when you talk, so you have to use your words. Adjectives are your friend when you get to the assessment and plan or impression and plan and putting that stuff down. But I think back in the day, because it was so heavily looked at with, a lot of practices would rely on the history and the exam to get their level. And so they really didn't pay too much attention to what they put in the assessment plan. Sometimes I would get a very short assessment plan and these big, long histories and exams because they said, well, right there. So I can just put, come back in 6 months and it's okay. And that habit is hard to get out of once you get into it.
Truly. But, I have been saying this for a long time since the new guidelines have come into play, right? we need to get our doctors and APPs back to what they were trained on, right? That clinical decision making is theirs, and we want that to be celebrated in this new style of documentation, right? Gone should be the old days of, just blowing up that history and exam for those bean counting points, right? We want them to get out of that bad habit that has formed. And you're right, it's like smoking cigarettes, right? It's a terrible habit to just break. It's really, really hard. But that's what we do in this field, is we try and provide the education that we know their thoughts are up there. We just want them put into the EMR. All of that brilliant thought process on, why this patient is so sick, put that down, and what we can do to help them get better, right? What kind of tests do you need? What kind of surgeries can we perform, right? We have to have that entire linear thought process happen throughout the EMR. So yeah, a lot of changes, right, have to happen because of these new CPT code guidelines and definitions, for sure, for sure. I don't think we're there yet.
No.
We have a ways to go, but slowly but surely we will definitely see improvements in the way things are documented from specialty to specialty. And I think a lot of them have more advantages with the new changes, but all of them have to jump on board.
Yeah. And speaking when we were both, when I said it and then when you said it too about the books and pages and all of that history and exam stuff in there, please stop doing it, y'all. You don't. I still see every time I audit, every time I look at records, I'm still seeing 3 pages of history and exam in there. I mean, it's just not necessary anymore. So
it's not necessary. And I do believe that's where we really have to get involved however we can, insert ourselves into assisting with the EMR changes in their templates that have to be changed, right? Because when you and I go in and look at these records, we're looking at the EMRs and we're like, wait a minute, that was from years ago. Nothing has changed, right? Because you and I have been around the block and these EMRs all still look the same, right? So it's that same templating that has to be done away with. And something new has to reveal itself, because that's the only way. We are punishing our providers, right? And saying, oh, but you keep doing this. Well, they're not doing it. It's the EMR that's been constructed for them to continue with these endless, histories and endless exams of every single part from head to toe that's unnecessary for the patient's presenting problem, right? They only came in for something very small. They don't need a head to toe exam for anything like that at all. So yeah, there's so much that needs to be worked on.
Yeah, and I think, and y'all that are listening too, I'm happy to hear y'all's thoughts on this. I think some of that template hanging around stuff is because some of the EMR systems, they say that used to be one of their big things. We have 1,000 templates and they're all in there for you to use, right?
That's what they said.
You can take use of, but then you would go into those templates and they were not the best templates sometimes. And so they would spend extra money either to consultants like us or to the EMR company to build them templates to their specifications.
Right.
So since they paid for them,
it was a lot of money. I understand.
Yes. And so I think maybe that's where some of it comes from, where they don't want to give it up, to where they continue to use them, because it's like, I paid a lot of money for but it's just wasteful. It's wasting their time. It's, it's just keeping up with that just bloated over information stuff. So change the that's a good idea. Change what they're doing, to just, bypass this stuff. It's just not necessary. It's only what's medically appropriate for that visit.
Right.
Teresa had a good comment here. if we could just get providers to use the AWV templates and the IPPE templates, for certain kind of visits, the annual wellness visit, the welcome to Medicare, the IPPE, that's not a bad idea to kind of look at those for some ideas on how to use your new ones. But the annual wellness visit and the IPPE, again, are specific kind of things, and they don't address some, like one of them doesn't really address problem things. It's not a problem visit. Right. So, but yeah, looking kind of, it would definitely be moving away from at least having to click 50 times to get through, the first page of the patient's template. Mm-hmm. So it really, needs to be looked at. So that is just my comment on that is I know that they've spent a lot of money on them in some cases, but they're really not doing them any justice anymore. They should, just stop. And it would make them easier. It would make it easier for them. They'd be happier. They'd be getting through it better. Mm-hmm. And then in the old templates, there might be some of that stuff missing in the medical decision-making.
Absolutely. Absolutely.
So Elizabeth has this comment that it's ridiculous to see templated notes. It should be easy for providers to document what they did on the date of service. There should be a way to fix that. The way to fix that, Elizabeth, is to just turn the templates off and
allow the free text. Yes.
But again, we go back to the habit thing. Right. So they're used to the templates. And so now if it's free text and they're having to go back in and starting to enter this information again, they still have those big note things in their head, I think. And they're thinking, oh, I have to do all the, no, why is the patient there?
Right. Simple. Simple.
Mm-hmm. What part of the exam did you have to do? Or a lot of them nowadays, we see a lot more scribes being used. So if you have a scribe, they're doing all that stuff.
Exactly.
Oh, yeah. Another point, Teresa, she still sees that greater than 50% of
the counseling. Time. Yes, for sure. It's still in there. That sentence needs to be gone. Yeah.
Yeah. So so these are kind of like the little things we're talking about when you start talking about the new stuff. Mm-hmm. Sometimes people just weren't thinking of these things. And now that they're actively doing these over and over, it's kind of like, well, why is that still there? And why is it, it looks like you're not attentive to being compliant, when it's like that. It's just kind of like slopped together. Yes. At least that's kind of how if I was a payor looking at it, that's kind of where I would go in my head. Do you agree?
Absolutely 100%. When I provide post education, those are things that I say, right? That I'm auditing your services because, I'm pro champion, love my doctors, whatever, right? I'm on your side and on your team. But objectively, if I was happening to be an auditor on the payer side, I would be dinging you for all of these things, right? Because it doesn't follow or support reimbursement policy. So everything would just be gone. So you have to be fair as well and honest in your education feedback, 100%. A payer would not look at it as kindly as we would, right? This is education because we want things cleaned up moving forward, right? Once I'm gone, in 2 weeks, I expect all of the changes to start happening, right? Start implementing what I said. So then when the payer comes back to audit you, everything is clean, everything is fixed up, right? Based on our education, our talking to each other the weeks before, right? So that's the goal. It's not for us to penalize, it's to help educate. So moving forward, you can take these considerations at hand and make all of those implementations to, again, protect yourself in this new landscape that our physicians and APPs are definitely in. And also what we always educate on is all of this was done to help you, right? Yeah. This is what the Patients Over Paperwork initiative was about. It was about you. It was about helping you spend much more quality time with your patients rather than on this quote unquote paperwork, right? It should not be so voluminous. We as auditors shouldn't have to be rifling through 75 pages for one date of service when you are not so sick in the inpatient, right, setting. You are simply coming in for an office, this, that, or the other, right? It's not that serious of an issue, but there is something wrong with you, but not 75 pages worth of our reviewing of documentation. So think of it like that, much more practically, that a patient, you yourself as a physician are a patient, right? And so you would never want to have that level of bloat for a service that you go in for on your own as well when you're not that sick. Have to think practically now as well, because this whole initiative was done to reduce all of this nightmare that we were tortured with for decades, right? It was a bad system, and we're trying to clean it up. So
yeah. And I, when I do audits for my clients, I tell them that I do them as if I was the payor. So I tell them I'm not being nice through this, you know, and when I do my reports, I make comments about a payor may look at this from this medical necessity, because that's how they need to see it and how they need to think. So for all of y'all that are in offices and practices and you do internal checks yourself, put that thought in your head when you're looking at the records. You're not going to do your physicians and APPs any service by looking at it and just going, oh yeah, this is great. You know, look at it as if you were the payor and not wanting to pay it. You know, like, what would I look at this, and is this ambiguous, and is this not clear? You know, give them that kind of feedback. That's what's going to help them the best.
Exactly. That's really well said, right? And I think you and I touched on this on a previous session together. It's absolutely true. When we always recommend that you do internal auditing, right? You look at your services once a month, see what's going on, right? Where is your weakness? We should all be doing that right now. It's 23. So things are brand new, right? There's a bunch of new CPT codes, a bunch of new guidelines. So nobody really knows what to do, right? So you should be internally auditing. But as she said earlier, when you're an internal auditor, you tend to favor your doctor, right? You tend to support them and not really look with a clean, objective set of eyes, you know? So sometimes as a provider, you may want to reach out to have an external audit happen, right? By people who are much more objective, who really want to help you clean things up and not just let you continue to slide with the way things have been done. So yeah, that's the good point that I wanted to touch on, that everybody is needed, but we need objectivity when it comes to our auditing.
Yeah. All right, we had another question that was on the FAQs there. If my provider is asked to consult on an observation patient, should the office or other outpatient E&M codes be used to report this activity? And the reason why I pulled this question out is because of how it was answered. Now, remember, this was a question that was put to the AMA. So the AMA says, no, use consultation service codes 99252 to 99255, because in the CPT book, these are now the inpatient or observation consultations. But the issue with that would be, what if it's a Medicare patient? And Medicare, of course, doesn't accept the consultation codes. You know, if you look at your MAC's site and look at their E&M stuff, like I was looking this morning on Novitas or Novitas, I don't know which way they like to say it, but they stayed on there, you know, like for observation, you know, they don't want you not only to not use consultation codes because they don't accept them anymore, but they don't want you to use the initial inpatient or observation care codes either, or the subsequent ones. They're telling people to use the office other outpatient. And I think that's where that question came from, is that she was thinking about that. That's why she asked, should we use the office other outpatient? That's really what I thought. But again, the AMA is going to answer as the AMA. So in their mind, we have consultation codes. So if anybody doesn't accept the consultation codes, that's when you fall back to this issue of how do I do it? So from a Medicare standpoint, you do have to use the office other outpatient codes for that.
Exactly, Betty. And I just wanted to circle back to the fact why I sent you all of the documents that you put as links for our audience. You know, I thought it was really good guidance that everybody should have access to, right? I don't know if everybody in the audience has signed up for the AMA's materials, right? But those FAQs have been updated, right, since the new guidelines came out for the 23 stuff. So, you know, it's really, really important to not only look at our AMA, right, when it comes to all of our commercial things, right? Because the AMA does not, you know, follow the Medicare stuff, right? They do their own thing. So like you just, you know, touched on, we have to also be looking at all of our MACs throughout the country that we happen to work in, right? Because all of them have published guidance on the new guidelines on their web pages. And the facts are clear from all of the MACs that they do not accept any of these consultation codes, and they haven't for quite some time. Yeah. So we do really need to dig in to those multiple web pages as well and see what each and every MAC is asking for in that specific question, right? Circumstance. What do we do? Because these inpatient observation things are so brand new. You know, what does each region suggest that we follow? So yeah, it's really important that we all use the published guidance that we have available to us and not just guess or try and use the outdated ways, because those guidelines are gone.
Yeah.
Right.
Or commercial payors too. I mean, the commercial payors, you know, sometimes they'll follow Medicare, sometimes they don't. So, you know, that's where, you know, at least I find with the MACs, they're better about having those things published out there. You know, they have to.
Absolutely. Yeah.
Commercial payers sometimes kind of hide them. You know,
they hide them all the time.
No idea where to find it on the site. Is it in this section, that section? You know, so sometimes it's a little rougher. But they could do whatever they want from payer to payor and from plan to plan. So that's where it's going to be a lot tougher with some of those questions.
Absolutely. And piggybacking off of what you just said, those commercial payers, if you happen to have a job function where you're the one that's picking up the phone and saying, you know, hey, Cigna, and they tell you that some representative that you're talking to says, we follow Medicare guidelines, but then you see published on the web, you know, a specific payer policy and they don't follow it at all. It's something of their own that they've constructed. You know, so you have to be really careful with when you pick the phone and say, hey, Cigna, because you just don't know if that representative is saying what's true when you're looking at their webpage and it says something completely different. So you really have to be very, very careful.
Always ask them to email that to you, please.
Yes, email. Get everything in writing. Yes.
Or ask them where on the website you can find that document.
Exactly. Please show me. Yes, please show me where I can find that support. Yes.
Because because if y'all change what you're doing and then you get audited by that payor and they say, you know, well, no, and our policy that's published on they're not going to want to hear you say, well, you know, the person on the phone, well, who was it? You're probably not going to remember because it was like 6 months ago. And, you know, so always you need the hard copy stuff.
Yes. Absolutely.
All right. So here, again, I picked this one because I thought that they misinterpreted what the person was asking again. Now, I might be totally wrong, but when I looked at these, I know I didn't think in the manner that it was answered. Okay. So the question was, the GP receives records from a new patient's cardiologist, which included an EKG, a chest x-ray, and all the physician's notes. So they said, can the physician receive for reviewing the cardiologist's notes credit one unique source, and the EKG and chest x-ray. Now, to me, what they're asking is, can they get 1 point for reviewing the notes and another point for the EKG and chest x-ray? They're asking, like, can I unbundle these and count these multiple times? That's what I thought they were asking. The answer that they gave was yes, but when you read the answer, it says review of all materials from any unique source counts as one element toward MDM. So if they were asking what I thought they were asking, can you count this as 2 or 3? The answer is no, because it's from one source. No matter how many pages it is, it's one element. Right?
Yeah. So when you and I get questions, I see your point on how you read that question, because you and I have spoken offline all the time for forever on these multiple types of questions that we get. And there is so much nuance to question asking, right? You can read it one way, I can read it another way, and then the AMA gives you that answer, right? But no, you're absolutely right in their answer, right? Our answer supports what they are saying. Absolutely true. But you cannot unbundle all of these items, right? Which is basically what that question was trying to do, right? No. So everything from that one unique source, you count as one. So of course, all of the labs, all of the, chest x-rays, all of the MRIs, the doctor's notes, all of that comprehensively, you can only count one time. It's coming from that one unique source. But yeah, Betty and I get questions like that are so complex, and you can see it multiple ways. But you really have to be able to filter in, what was the questioner actually trying to ask? And absolutely, if you're trying to elevate, that's a no. Like,
yeah.
No.
Yeah, and that's when I end up where people say, well, it's just a quick question. Yeah,
it's never a question. It's never a quick question to a consultant,
like
ever.
This question,
never.
We could give 3 paragraphs back as
Correct.
an answer, because it's
Correct.
like, if you meant this,
right.
then here. If you meant this, so right. a lot of these things, yeah, you could go off on so many different tangents for
Correct.
things that,
Correct.
You can't tell.
Yeah.
And another one we had here was about the inherent risks. So the question was, do inherent risks, like a perforation, perforations, possibilities, that kind of stuff, make all surgeries high risk to patients when selecting the level of risk for medical decision making? Okay. No. The way I look at it when I think through this is that it's kind of like, I liken it to prescription drug management. At least that's how I kind of think. Like, if you just see a laundry list of drugs at the end of a note, that's not prescription drug management, right? Nope, you have to see that it says continue on this dosage of whatever, or this dose is fine, or I'm upping this one, or they can stop this one. You have to see management.
Yep.
So it's the same kind of thing with risk. Just on every note, every time somebody has a procedure, if they say, told the patient about the risks, bleeding, blah, 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 and death, because that always has to be thrown in there at the end. I love how that just sneaks in there, right? And then it just goes on. That to me is the same thing as like just listing a bunch of drugs. You're just throwing it out there. What I look for is when it says, due to the patient's diabetes, explain that, they're at a higher risk for the wound not healing, so they're going to have to keep an eye on it. Right. So when I look at things like that for risk factors, like available to, like, again, on the risk column, bump it up from maybe a low to a moderate, or a moderate to a high. That's what I'm looking for. Do you have comments on that one, Sonal?
No, that's exactly how I see it. I wrote an article for NAMUS recently where I addressed something to that effect, that in my opinion and in my experience of my surgeons' documentation that I've seen, they've always done a really, really good job of explaining much more of the risk that you and I want to see, right? They've already been doing a great job. But in this new landscape, that's exactly, we don't want to see just the laundry list. Obviously, a surgery is always going to put you at risk, right? Anytime you're put under, there's a risk of you not coming out, right? So that's just going to be a given. We want much more for that particular patient, right? How is that patient at risk, right? It's much more about that as well. So yeah, I completely agree with you that those types of things we need to see in the documentation to support the risk category to be elevated.
Yeah.
And you can't just elevate everything to a 5 because the patient is going under the knife.
Exactly. Yeah. And Lady makes a good, the key word is management. So that's kind of how like I said, I kind of liken the two in that manner that, yes, it's got a risk, but how is it personalized to that specific patient?
Right.
That's what you have to drill them down to.
Yes. Everything in this new landscape is individualized to the patient. It's all about the patient and the patient's risk.
Yep. Now, this is one of the questions that was sent to us, and I had to put it in 2 parts because it only takes 200 characters. So it says, so if the ER doctor sees the patient and admits him to observation, and then seen by another doctor of a different specialty, does the ER doctor append the 25 to the ER visit, or is the other doctor appending the 25? And then the second part as it went on, or is it saying if the ER doctor sees the patient and then that same ER doctor sees the patient again in observation, he appends the 25 modifier? So, Sonal, do you want to take that one, or do you want me to do it first?
Okay, so I think what this new guideline is intended for, right, is if a doctor sees the patient before somewhere else, like in the office, and then they're going to send them off perhaps to be hospitalized, right? So in that situation, these new guidelines allow that physician for the office to append the modifier 25. In this particular situation, she was talking about, or he was talking about, the ER setting. Can you put that question up again for me?
Mm-hmm.
Okay, so if the ER doctor sees the patient and admits him to OBS, and then that patient is seen by another doctor of a different specialty, does the ER append? So she's asking, she wants to append the ER visit, the 99281 or something, with a modifier 25?
Yeah, I think what she's asking is if 2 different physicians see the patient on the same day, one in the ED, one in observation, do they have to put a modifier 25 on their E&M codes? And the answer would be no, because they're different people, different specialties, don't have anything to do with each other. That's how I was reading what she was saying. Because especially with the different specialty issue.
Right, it's a different specialty. Yeah, right.
But, your point about the new guideline, is if it's the same person doing the same thing, kind of, I think from an ER standpoint, especially if it's inpatient, that kind of thing, they usually don't do it. They don't do it. So it wouldn't come up. But the other thing about that modifier 25 thing to remember, y'all, is that Medicare is like,
right. They play their own game.
You can't do that with a Medicare patient. Right. Medicare still wants you to roll it together and bill them one thing. Exactly. They don't get on board with the whole modifier 25 issue. No, they don't. So yeah, in that case, 2 different doctors, different specialties, they just each bill their own thing. They're good to go. Yeah. Right. Now I saw, this was one that somebody put me on LinkedIn, but I think it's more of a diagnosis question. but my answer, I think we addressed this in a prior thing. It was kind of similar. So she had a patient that was in an observation setting. The provider was documenting pyelonephritis, but the discharge status had no signs of pyelonephritis. Which one would you use? And my answer at that would be to query the provider.
Right, for sure. You definitely have to.
Yeah. I just didn't want the person that sent this in to think that I kind of ignored the question.
Yeah.
But yeah, anytime you get things that are not clear or conflicting in note, always query the provider, because if it's conflicting for you, if a payor's looking at that, it's going to be the same thing, you know?
Yeah.
Now I did see somebody here put out a question here. Sana, if a specialty physician recommends surgery, but the patient denies it, does that count in deciding the E&M level?
Yes.
Absolutely.
Absolutely. Yeah. I mean, based on our new guidelines, right? Finally, they get credit for the consideration of management, right? So absolutely, that's going to affect the E&M.
Yeah, remember when you look at the bullets under the risk, it's decision for surgery, not that they're going to have it or you schedule it. Right. You know, same thing with medication. If the patient comes and they have like a funky rash, and the physician says, or the APP says, you know, I want to give you this steroid, you know, prescription cream. And the patient's all, you know, oh, no steroid, no, you know, I don't want to, even if it's a cream, and they get all freaked out and they say no, and they don't take it. Well, that's still what you said they needed, even though they refused it. That was still your decision making. So you still count it.
That's
you know,
right.
you just have to make sure they document that.
Document it.
Patient said no, then they don't have it in there. Make sure they say offered patient this and patient refused. So same thing, Sana, for this. If it says recommended, you know, patient have their gallbladder out, or they have this or that, and the patient at this time refuses, that's your decision. So you would count it, but they have to document that.
That's right. That's a great question.
Like, and here, Teresa, yes, it's like the same with global days, since casts have 0 global, right? When you're looking at major and minor, it has nothing to do with the global days from Medicare, according to CPT. You know, and the cath is always the example I give. If you're putting stents in the heart and all that, I'm sorry, that has 0 global days with Medicare, but that is not a minor procedure.
Right, that's not minor. No.
So, yeah, so it behooves the physician to say, major procedure recommended, minor procedure. If you could get them into habit of saying that, that would be very, very helpful. But that's a hard pull.
That's a hard pull, because that's definitely a hard pull, because they're not trained to write those words in their documentation, right? Major and minor. That, I believe that's also up to us as the coding professionals to understand what the procedures are, right? Yeah, exactly.
Now we're at time, but I have one more question that came in here that I think we can do.
How is it this fast already? Oh my goodness.
I know. Okay. What is your interpretation for escalation of care? So when they put it in there before, it was for inpatient admission. That's when you would need it, right? But now, since they've added inpatient codes in, it can't be just for inpatient admission if they're already an inpatient. Then you would never meet it if they were an inpatient.
Right.
So when you look at escalation of care, if they're on a regular floor and then they have a downturn and they go to the ICU,
they go to ICU.
Escalation of care.
That's escalation. Absolutely. Yeah.
Would you look at specialty floors also as being escalation? I just thought of that. You know, like if they're in a general bed and then they move them to the cardiac unit.
I would think so. I would consider that escalation of care. And again, that all has to be documented. Absolutely. To be moved from a general section to the cardiac wing, absolutely. That would be an escalation of care. Yeah, for sure.
Yeah. So yes, and another thing, and that just brings out another point to consider, is that y'all might want to add these things in your compliance program and your evaluation and management policies. Put these things in there that are common things that come up.
Right.
And then if I pay your audits, y'all, you send that along with it.
Exactly.
Exactly. And then, I'm seeing now people are asking questions. So this is another quick one, y'all. Sorry. If a patient denies prescription drugs and wants to get OTC drugs, does it still count in deciding the E&M level?
Yes. Absolutely. Yes.
So they said you need a prescription. Patient says, no, I want something over the counter. You still count it as prescription drug management.
Absolutely. Because you considered it. Absolutely. Okay. Yes. Good.
All right. Well, yes, we are at the end of time. And once again, y'all were just getting started in here with asking us questions. So maybe this E&M one, Sonal, maybe we can do it like quarterly or something like that.
Yes, I think we need to. Yes.
And have people just send us stuff because this seems to get, well attended and lots of good questions.
Lots of amazing questions. Yes. Yeah. And, we just started on 23, right? And things have changed. And so I think that's a great idea to do this from time to time, just to see what people have to ask. Absolutely. Because I don't think we're you and I are even done yet, right? Talking.
No. Yeah. We still
digesting all of the changes.
Yeah.
Exactly. Exactly. Yeah.
Great. And I just, as a last thing here, I am going to be speaking this Saturday at the Northwest Indiana Coders Spring Seminar. So I just thought I would put some information up here for that, and I'll put that in the chat too if you want to go check that out. We're going to be doing a 4-hour seminar, 4.5, it's 4.5 CEUs. And we're going to be talking about the differences between inpatient and outpatient coding, like DRGs versus CPT and the UB4 versus the CMS 1500, all that kind of stuff. So I put the link down in the chat if y'all want to go check that out or sign up for it. It should be a good seminar. But thank you, Sonal, for joining me again today. And don't forget, y'all, we have coming up, not the next time because I have Rosemary next, but the one after that, Sonal's back on, and we're going to do our part 2 for the audits when we talk about actually doing the audit.
That's right. Can't wait.
So that'll be a good one.
Looking forward to it. Yep.
So watch for those notices coming up. And again, make sure you're checking Sonal out on her podcasting, Paint the Medical Picture.
Yes.
And her LinkedIn, where her SP Collaborative, her new venture is. Here is her link. You can find her on LinkedIn under her company and under herself. So make sure y'all are connecting with both of us and follow us so that you see all the stuff we always are throwing out there to kind of get everybody talking about stuff. But thanks everybody for joining us today, especially you, my friend Sonal. Again, I appreciate you. So y'all have a good rest of the day and weekend, and join us next time to see what's happening in healthcare, and we will take it from there and just keep moving forward. See y'all.
Thanks, Betty. Bye.